Okay, there we go. Welcome, Jim, to the Fabulously Keto podcast. It's fabulous to have you with us today.
Thank you.
And we always start by asking our guests, where in the world are you?
Well, I'm actually in Fort Myers, Florida, because I'm down here with my daughter. But I live in Evansville, Indiana. That is a city on the Ohio River, and as far south as you can live in Indiana, because we're down in a little tiny toe-shaped section of the state. We're actually further south, for people listening in North America who might realize this. We're further south than Louisville, Kentucky, and Lexington, Kentucky, and thus my Southern accent. That and the fact that my mother was from Tennessee and my father was from Kentucky.
I love that Southern accent. It's really cool.
It's kind of a, we call it sort of a dirty accent because it's not as refined as the Eastern Kentucky accent. It's not as refined as some of the, some of the people in the far South.
Yeah. Great. So we want to find out how you came, because you've been low carb for a very, very long time, haven't you? So yes. Take us back and tell us, what was happening before and how did you find low carb and what made you take it up?
Well, I came to low carb quite by accident, and I was at a grand rounds at one of the hospitals where I worked, and there were two physicians presenting, a man and a lady, and it was a grand rounds on obesity and obesity treatment.
Before you go any further, can you, for those of us that are not in the States, what does grand rounds mean?
Grand rounds, those are educational conferences. Most hospitals will have one on a regular basis. And if you're in a residency program, you're going to have those on a regular basis. So it's an educational conference. Usually they're about an hour long. And it's just to educate the medical staff on particular subjects. And this one focused on obesity, but they went into low carbohydrate diets. And specifically, they mentioned Atkins, because this was back around, I just rounded off at 2000, 2001. Mm-hmm. And they talked about the Native American population here in the States that had been devastated by the Western diet once they had been placed on reservations. And they mentioned that the average age of a Lakota woman, average lifespan was like 54 years, because they were all obese. They all had serious cardiovascular disease, which we now know is related to carbohydrate intake, and which was quite the contrary to what their natural state was when they could only eat real food and they could only eat grains and fruits in season. So that impacted me because I have a significant family history of cardiovascular disease. And when I was going in for my annual checkups, my cholesterol started going up a little bit. Because I've been a lifelong exercise nut, I felt like that's all I had to do, to maintain my health. But because of other grand rounds where I was going in and to cardiovascular grand rounds and listening to their presentations on lipids and cardiovascular disease, I realized that, well, you're not going to control your cardiovascular risk factors by exercise alone. That's not going to work. And that made me decide to try a low carb diet, because I believe one of the things that they did mention, okay, because we didn't know nearly as much then as we do now about doing a low carbohydrate lifestyle. They did mention is seeing improvement, particularly in the lipid numbers. There was really no mention of diabetes or treating diabetes that way. In fact, most physicians wouldn't talk about it. And I had people poo-poo me about physicians, no, to kill you. You'll have, we've all heard this now. You'll get kidney failure. You do this, that, the other. So, but I decided I was gonna try it at that point. And just for some reference, my family physician had started me on Lipitor, and I was only like, I was maybe 45 years old or so. And my cholesterol had gotten to 204, my total. I don't even remember what my other numbers were. And I went on the Lipitor, and my total cholesterol went to 185. And we're talking about the units we use here in the States. So mine went to 185. And then I went on the low carb diet, but my triglycerides were high as well. Now we know now, and I should have known because my interest in undergraduate school was biochemistry. I used to know all the biochemical pathways, but that was long gone several years into medical school. So, or this was after I finished my residency. So I went on a low carb diet, and it dropped my cholesterol to into the 130s. Okay. So it did a much better job than the Lipitor did. And then not only that, my triglycerides, which had been at 300, and they've been at 300 because, you know, when I'd sit and study and stuff, I'd eat candy, you know, I'd put sugar in my coffee, you know, crazy stuff like that, you know, and luckily I wasn't big and heavy because I worked out all the time, but metabolically I was a train wreck. I was becoming a train wreck. So I saw my triglyceride come down. I saw my total cholesterol came down. My LDL went down below 100. As we know now, that probably because a lot of the presenters I've seen on your broadcast, like Dr. Tim Noakes and Dr. Gary Fedke, and we now know that fat and cholesterol numbers in and of themselves probably are not predictive at all of cardiovascular disease. Insulin resistance and sugar are. So anyway, that's what got me started. So I started, again, about 20 years ago. And
so
go ahead.
Just from that talk made you decide that you're going to try it. That was quite brave of you, wasn't it, at that time?
It was, but again, going back to, I went home and I still had my old Leninger biochemistry book. And I used to get these big, like, poster board, and I would draw out the chemical pathways on there, the biochemical pathways. And I can't even remember those now. Don't ask me to draw any carbon and hydrogen and, you know, the little stick diagrams. But I went back and looked at them then, and you could see and looked at the pathways, and I thought, what in the hell is wrong with us? These were worked out probably, I'm not sure how long ago they worked out some of these pathways, but a lot of them have been worked out, from my understanding, in the 50s or 60s. So we already knew that. We knew what happened to sugar when you ate it, you know, and we knew about sugar and fat and protein metabolism, but we weren't applying it. So that gave me a little bit of courage to try it. And I did. And except for that little bit of a hangover you get for that first week, which was tough when I was running, I felt great.
Yeah. So you said your cholesterol numbers came down, and you're very lucky because mine have gone up. But what other benefits did you notice?
Well, what's interesting is that, you know, I mentioned in the pre-show little bit of a discussion we had, that I stay very active, and I play senior softball. And now this would have been back when I was in my 40s. They call it master's level at that level. It's not till you get over 50, they call you senior. But anyway, there was a guy on the team, and he's probably the first guy I met who said he was going low carb. Now, this fellow was, I don't know what his degree was in, but he worked for Indiana University. He was kind of a researcher. So he had science and medical background. And I remember saying to him, he went by his initials, RT. I said, RT, you sure you should be doing that? You know, while you're trying to play ball, whatever. And he said, oh, it doesn't bother me. Okay. So when I did it, I noticed my endurance got better immediately. Now, you know, in a study, they say N equals 1, you know, so was that placebo with me or whatever? But now, almost 20 years later, at my age, I'm 68, I'm still playing. I don't get tired. Now, part of that's genetic, because I was always able to just go and go and go and go. I'm not big and strong or anything, but I can run, you know, and so, I mean, you know, I run for other guys now, and I play every inning, and I play outfield, and my endurance, I think, is better. Now, what's interesting, let me think of who is it Dr. Paul Mason? I watch you watch all these medical lectures now on YouTube, which is great. He showed a couple of papers where they looked at people who were keto adapted and endurance. And they do better. And if you think about it, you get 9 grams, you get 9 calories per gram of fat. You only get 4 from protein and sugar. And we now know from Dr. Tim Noakes' work that carb loading doesn't really work. If you go past 4 or 5 kilometers, it just doesn't work. And so that's something I definitely noticed, that in my daily exercise, because if weather's okay, I'm biking every day or playing ball. I noticed, at least in my case, a definite improvement in my endurance. And but I think there are studies now to show that that's the case. And so that's, if someone is afraid to try it because they're into athletics, or whatever, running or walking or whatever it is, and they think it's going to affect them, I would say I think you'll see just the opposite. And I think the data is there now to prove that. That's not just something I observed. We've seen that in other people.
I think you just have to allow some time for that adaptation to switch over, and it might be weeks, it might be months if you're doing a very high performance sport.
Yeah, well, that's exactly what the studies he showed. That's exactly what they showed, that it can take weeks or months to get to that point. But if you're not doing real endurance stuff, there's no need to get there in a hurry anyway. You just want to stay healthy. Absolutely.
So tell us a little bit about your career in the medical profession.
Well, I'm a colorectal surgeon. And so I did a 5-year general surgery residency at Michigan State. And then I did a year of colorectal surgery at a place called Ferguson Hospital, Ferguson Clinic, which at the time was the only freestanding colorectal hospital in the States. We had St. Mark's in London, famous colorectal hospital, but we only had one in the States. Now it's now been absorbed by Michigan State. And so I did a year of colorectal surgery. So my practice involved doing colorectal surgery for 30. I'm retired from actually actively seeing patients. I still work for our group as a consultant, and I help our nurse practitioners and such. But I was doing colorectal surgery for 32, 33 years, which meant I probably have done 60,000 colonoscopies, because colon cancer screening is a really big part of our practice. This kind of goes to what we're starting to see now, unfortunately, with just a few providers, but in medicine, where rather than waiting to treat the disease like diabetes, you work on preventing it. Well, colon cancer is largely preventable if we do colon cancer screening and remove polyps before they become cancers, because the vast majority of colon cancers can be prevented if people have colonoscopies and have polyp removal. So that was a big part of our practice, is doing screening. But then, of course, we also did the surgery for patients with colon cancer. We took care of patients with inflammatory bowel disease, both ulcerative colitis and Crohn's. We did both. Now I liked to do a lot of the medical management. Some of my partners, not so much. They would leave the medical management to the gastroenterologists who also do colonoscopy and do upper endoscopies. But they also they do the medical management of GI disease. But I always enjoyed doing some of the medical management as well. And I never did get into giving them the monoclonal antibody therapy. I let the GI physicians do that. But managing some of the other not over the counter, but some of the oral medications, I would do that, and trying to help them manage their disease. And then we take care of anorectal diseases. It used to drive me crazy where I'd see the comedians on TV. They would talk about seeing their proctologist, and at least in the States, I don't know that there are proctologists anymore. There used to be a specialty that was proctology, and those were physicians who had spent 1 or 2 years just doing training on taking care of anorectal diseases. In other words, hemorrhoid problems and anal fissures and pruritus and abscesses and fistula. But we took care of anorectal disease as well. So that's what I did for 32, 33 years.
Did you see an increase in colorectal cancer over the years, over the decades?
Well, what's interesting is with really pushing screening colonoscopy, we were seeing a slight decrease. We had seen a slight decrease in colorectal cancer over the last couple of decades, but it's directly related to the screening, because we really haven't, because we were teaching that red meat was bad and that fat was bad, and that those increase your risk of colorectal cancer. And there's no scientific data that shows that that's true. In fact, I can't think of the fellow he has a Polish surname, but he's Australian. I just watched him give a lecture on red meat, and there's absolutely no data that red meat increases your risk of colorectal cancer. So I've been pushing on my patients. It doesn't work for very many people for years. Cut your carbs out. Cut the carbs out. So we don't know what effect that might have if we do that. If we can do that on a national and certainly a worldwide basis, we don't know what effect that will have. But we'd seen a decreasing incidence of colon cancer, but it's because of the screening. Because luckily enough for colon cancer, a little different in some diseases, you in the vast majority, 99.9% of cases, the person develops a polyp first. It takes a number of years to become cancerous, but the polyp's abnormal. That's an abnormal growth. And we feel like, and again, we don't have data to show this yet, if we could get people to reduce their carbohydrate, you're going to reduce the development of polyps. Those are abnormal cells. Those are cells that are probably already, and again, I don't know this for sure, but my hypothesis is they're in the process of changing their energy production in the mitochondria. And when they get to a certain point, then they're full-fledged cancer cells. And here's the thing: we know once a person has developed a polyp.
Sorry, I don't know why that came on because I put my phone on Do Not Disturb.
Sometimes if you've got somebody as an emergency contact, or it'll let them, at least my phone let them go through. Yeah. So that's okay.
Yeah, it is my sister.
We live in.
It is my sister, and I said allow calls from no one, so I'm not sure why it came through. Sorry.
I mean, if you need to take it, go ahead.
No, I don't.
Okay.
So, so let's just go back to, because I'll cut this bit out.
Yeah. So about polyps and cancer.
Yeah.
So I have kind of a theory that so there's definitely like with everything, a hereditary predisposition, and we know if you have a first degree family member or two second degree family members who have had a polyp or cancer, it increases your risk of developing polyps and cancers. The overall risk in Western Europe and the United States of developing a polyp is about 30% by the time you're age 50 to 60. Some of that may be genetic. We don't know yet the influence of diet, because we've been telling people that red meat and fat are bad and increase your risk when we know that doesn't now. It just doesn't. What's common, and this was what was great about the lecture. So the one thing that's common in people, because and when you do these epidemiologic studies, he makes the point you can see correlation, but you can't make you can't ascribe causality. Did it cause this? And he pointed out that when you look at the relative risk increase, it's nothing. It's like 1.18 or whatever for red meat in these populations. But he said, here's what we don't know about them. We don't know what their carbohydrate intake is. We know they're not on low carb diets, and we don't know which ones are smoked. Well, that we already know
smokers.
Bad. Yeah. Yep. And so he says it's interesting. We completely ignore the influence that carbohydrate could have, while we want to blame it on red meat, or we want to blame it on fat. Yep. And in the Women's Health Initiative that was done here, and I think concluded in 2005 or 2007, and Dr. Tim Noakes has talked about this a lot. If you look at the women who are on a low fat diet versus eat whatever you want, and you got to remember now, in this country at least, low fat was already, they started pushing that in the 1960s.
Yeah.
So even the women who were told they could eat what they want, I mean, when they everywhere, anything you pick up off the shelf said low fat, low fat, low fat, but they were told to eat what you want, and the women in the low fat group had a higher incidence of breast cancer and colon cancer. They had a lower incidence of breast and colon cancer in the group that ate what they wanted. So there's just, so I was always telling my patients, eat what you want. Don't eat what you want. Keep your carbs down. And the problem, and you guys are probably more aware of this than I am, very few people pay attention to you. They just don't pay attention. And they're so, like in my own family, as an example. It's like my sister-in-law, Billy. Well, she won't eat, she won't, she keeps her meat to a minimum. She eats fish and she eats all these grains. If it says whole grain, whole
healthy grain.
Yeah.
Yeah.
And I keep telling her, I said, Billy, but she's 74 years old. I don't know that I'm going to get her to change, and I've sat down with her and watched some of the documentaries that you can pull up on Amazon and Netflix. And I think she's set in her ways. She just does.
And I think as people get older, they sort of think, well, I haven't got that long left. Why worry about it? I know if my mum was to pop her clogs tomorrow, she doesn't care. She feels like she's lived her life. She's had a good time. And if it's her time to go, she'll go. She won't mourn that. And I think maybe as you get towards that age, you start to think differently, I suppose. But
I may be close to your mom's age. I'm 68. My wife's 68. She and I are planning on living to 100.
You're in the middle. You're in the middle of her and me.
Okay. Yeah. So, but no, I think that's very true. There's no question about that. And some of that, I think, could potentially go to quality of life in some people, because there's a difference between living to be old and being healthy and older. And I mean, I was, I rode my bike 10 miles yesterday, and I stopped at a soccer field and ran sprints so I can stay in shape for softball. I don't know that most people 68 do that. I know guys I play with do, but we're definitely in the minority.
Yeah.
But I mean, I hope that's something that as the years go by, we can convince the general public of. It's not just important to live long, but to live well, to live healthy. And I think that's what you can bring to your life if we can convince people of doing that. But you're right. Some people are, hey, I'm comfortable. I've lived a good life, and that's okay. It's a choice that we all get to make.
Yeah. And I'm lucky that she is healthy and she is mostly low carb. She doesn't do any exercise, which is always a bone of contention with her and I. The two things I'm always going on about is you need to move more and you need to eat more protein. Protein, you need protein. But she's not that keen on meat, so she doesn't eat enough protein. And I'm always going on about that to her. So I do nag her a bit, but not too much. But within herself, she's quite healthy.
Yeah.
So but I think that is really important, that we have a quality of life, that it doesn't matter how long you live, but it's how you live in that time that you're living. Because if you live an extra 10 years, but those 10 years are spent in a home or a care home, and just sitting in a chair, watching television and listening to other people shouting around you, and, that's no quality of life.
Right.
That's not enjoying your life, is it?
No, exactly. I subscribe to Are you familiar with Dr. Peter Attia?
Yes.
Yeah. So I listen to him a lot. Working just part-time really allows me a lot of time to I love to, I learn better listening to a lecture sometimes than reading. And he makes that point that, what we can improve on is we don't want to just improve on the length of our life, but the quality of our life. And if you look at the things that he does this thing, and I'll probably get it wrong, so don't blame this on him, but he looks at the causes of death, and at least in Western society, it's cardiovascular, it's heart disease and stroke, it's cancer, and then it's dementia, or cognitive impairment. And then, so I think I saw him do it where he draws like a little pedestal, and those things are on there. Then at the bottom is sugar and insulin resistance. And that's what supports all three of those. That's what causes, if you want to call it, all three of those, of those causes of death. Now we're excluding accidents, trauma and that kind of thing. And diseases or infectious diseases. But those are the big causes of death. But not only do they kill you, they really they really impair your quality of life. They really do.
Yeah. Yeah. And your lifespan, you can see the deterioration over time.
Yeah.
Whereas I don't know about you, but I would think, we are living, and then the idea is you just fall off the cliff at the end.
Yeah.
Sit down in your chair, go to sleep.
I have an interesting story about that. I went to an American Cancer Society. It was a fundraiser, and it was like a silent auction and a dinner. And afterwards, a few of us went out for some drinks. Several of the couples, and I was only maybe 35 years old at the time, and I'm not a golfer. In the States, everybody golfs, and if you're a doctor, they think, oh, you golf. I've never been a golfer. I always said I would rather have somebody else chase my ball. That's what we say about, because we hit the ball and other people have to chase it when you play baseball or softball. But one of the wives asked me, well, Jim, what do you do for hobbies? And I said, I love to read. I said, well, I read, and I run, and I play softball. And she gave me a dirty look about the softball. It was almost like she like that was beneath me. As a doctor, I shouldn't do that. And I don't know why, but she did. And her name was Laura. I remember her name was Laura. And I said, well, Laura, what would you have me do? Just go to work every day, come home and sit on the couch and wait to die? I'm not going to do that. And I've always remembered that conversation, because I've kind of tried to live my life that way. I mean, we are lucky to live when we do, and to know the things we do. And I think, thank God I'm blessed every day that I grew up in an era where we have modern medicine, where I could get an education and be able to teach myself and teach other people how to be healthier. We live in a fantastic time.
Yeah. So how did you manage to incorporate low carb into your practice? And the practice where you worked, how accepted was that?
Not because I have a partner, great guy. His name's Dr. Santiago Arafat. He's interesting history for him too. He was born in Spain and moved to New York when he was 2 years old. So anyway, but he is a great guy, a really good surgeon, just wonderful person. I have another partner, Dr. Dean Smith, who's the same way. He's from Pennsylvania. I think he went to Penn State for medical school. And Dr. Heather Matheson, we tease about this because Indiana, Kentucky have a rivalry. She went to UK. But the three of them are not going to go long. In fact, Dr. Arafat eats what he considers very healthy. Lots of grains. Well, he's almost vegetarian. He calls himself vegan. And I go in all the time and I pick up his little things of food. He doesn't mind me telling the story because we laugh about it. And I'll pick up this box of whole wheat crackers or something that he's having tuna on. Okay, he's having something healthy on that. And I'll take my little yellow marker and I'll circle how many carbs there are in like 24 grams of carbohydrate. And say, Biago, that's killing you, So yeah, it's difficult. I could tell my own patients, and I preach it to everybody I see, lower your sugars. In some of my YouTube stuff, I said, when I talk to people, I say, lower your carbohydrates, do some exercise every day. But it's tough. And I'm sure you guys have found that too. I mean, you guys are educating many, many more people than I do. But it's tough to get people to do that. They're comfortable with their way of life. And it does require some discipline to make that switch, and when I listened to your podcast, Martin, and you two were talking about transition. Yeah, I get that. That's, you've got to stay focused at times.
Yeah, because the easy option is to do what everyone else is doing.
Yeah.
And that is generally extremely high carb.
Oh, and now what's interesting is I've had two converts at my office. We have one of our nurses and her husband, and I'm guessing they're probably mid 40s. He developed diabetes, and she knew I was on a low carb diet, and she asked me about it, and I said, here's some sources to go to. And I checked back in with her a couple of weeks ago, I said, Jinky, their name's Jinky Mokia. They're originally from the Philippines. And I said, Jinky, how's your husband doing? He's lost 35 pounds.
Wow.
He's off he wasn't on insulin. I think he was on metformin. He's off his medicine. And I mean, and that makes you feel good. And that's, it's one of those things you just have to keep preaching to people, but it's those successes. And so she went low carb too, because it's easier to do it as a couple.
Absolutely.
But yeah, it's tough. So I go in sometimes, like in the break room we have. If somebody's having a birthday, it's a special day or whatever, you walk in there and there's nothing but pastries on that table. There's cookies and cakes and donuts, and I go in there and take a picture, and then I'll tease them all. I'll say, that stuff's killing you. And yeah, and you just, you hope you get somebody to do it. I think some patients, because I would tell them, after their colon cancer surgery, or even going into it, even before, I would talk to them about that. And some do, because, that's a big life-changing incident for them. First of all, they've had to have a surgery. Now, granted, the last 10 years of my practice, we were doing most of them minimally invasive, just 3 tiny laparoscopic ports, but it's still a big surgery, and you're faced with something that's a life-threatening disease, depending upon your stage. And a lot of those people, you could get them to make a change. And because one of the interesting things that we now know about cancer, and as I've said many times, I slapped myself in the head when I first started listening to some of the lectures about this, like Dr. Don Lemaine at Stanford. I got to think of some of the other people I can't think of the fellow's name. He is from University of Pittsburgh. They've been doing studies on reducing carbohydrate intake in cancer patients, and it's of a definite benefit. So that I've recommended that to my patients now for several years, go low carb. And I've talked to the oncologists about it, because they're the ones, if I have a patient who has what we call stage 3 or stage 4 disease, where they will get chemo for a certain period of time after surgery, what a lot of these studies are showing now is that because the mitochondria, which is like the little engine in our cell, they most if not all solid tumor cancer cells can only burn glucose and glutamine, but glucose is the major source. And what made me bat myself in the head was, okay, I've been ordering PET CT scans on people for years, both as a pre-op evaluation to see if they had metastatic colon cancer, and then post-op to follow them. And that's based on glucose. We take sugar and we tag it with a radionucleotide, and you give it, I don't do it, the radiologist does this, but we give them that, and the cancer cells suck up the glucose because that's all they can metabolize. Yep. And so we're now using that knowledge to treat people. And I've got several of the oncologists in Evansville, and they know the data too. So they're encouraging their people to go low carb. A lot of people won't go low carb, but if they can't get them to do that, if you can get them to fast for 12 to 13 hours before their chemo, the chemo is much more effective. Yep. And you may be aware of that. It's much more effective, and it's much less toxic to the patient. So you can give less chemo. And I know Dr. Lemaine, I hope I'm pronouncing her name right. I know that in studies that they're doing on breast cancer, they still are treating their patients with tamoxifen and radiation, but they're having one group fast and they're having the other group just eat normally, and they're seeing much better results than the people that are fasting. Wow. And so I think we're going to see that, and we've seen that, I believe, with the astroglioblastoma brain tumors that were not very, not very affected at all by any treatment we were doing. And so I think we're seeing that as a new therapy. And what's interesting is the Soviets, after World War II, they did a lot of fasting therapy. They did it for everything. And they could put people in a sanitarium, and then they could control their diet. And after the fall of the Berlin Wall, when researchers actually got a chance to look at the data, they found there were a number of things that actually improved with fasting. Well, we know about diabetes, you know, but they also found that cancer patients, they had a better prognosis. It didn't mean they were necessarily, they had better quality of life. Didn't necessarily mean they were cured, but they had, their symptoms were lessened, and they live longer. And so that's what we're seeing now in some of the ongoing studies looking at cancer treatment.
Yeah. Yeah. So, forgot where I was going to go with this.
Hey, you can go somewhere else.
Yeah, it's gone. It's gone. So just give me a minute, because there is something there. So if you had people that were coming to you with colorectal cancer, and you were advising them to go lower carb, of those people that you mentioned it to, what proportion do you reckon took you up on that offer?
I'm guessing maybe only 5 or 10%. And that's just purely a guess, because I didn't do any, I didn't do any studies where I had them come back in and, they'd come in, how you doing? What are you eating? And you never know if what they tell you, they may tell you what you want to hear, so
yeah, that's true.
That's why studies like that, when you see these epidemiologic studies looking at diet, whether it be olive oil or, the Mediterranean diet, or you don't know, because they're doing a journal. They're keeping track that way. I just would encourage it. I'm sure some people did, because I would see people who not only were did I feel like they were telling me the truth, they were exercising. And what's interesting is in my period of time in surgery, when I started medical school in 1976, but when I started my general surgery residency in 1980, we made people stay in bed. We were just transitioning from that era of they didn't let people do anything, to where I told them, do whatever you're comfortable with. I had a fellow one time who was 75 years old, and he had a colon cancer operation, and he rode his bike every day. Now, this has been back 25 years or so ago, and it just so happened at lunch back then, there was a park near my office, and I would go run at lunchtime if I had time. So when this guy, when he was getting ready to be discharged from the hospital, I said, "Hey, doc," he said, "now, when can I start riding my bike?" And his wife immediately piped up and said, "You tell him he can't ride his bike." And I said, "Well, I can't tell him that." Let's just say his name was Oscar. I said, "Now, Oscar, how heavy is your bike?" And it was one of the, lightweight, even 25 years ago, fairly lightweight bike. And I said, "I don't want you doing any real heavy lifting or straining over about 20 pounds, because you get a hernia at the incision site. But if you're just getting on the bike and you're riding, on level ground," I said, "you go ahead and ride." Because I was telling everybody to start, and people who were not, well, anyway, about a week after he was discharged, I'm over there running at lunch, and he comes to and by on his bicycle. I had probably seen him out there many times, but didn't know him before I saw him as a patient. And he hollers at me from a distance, "Hey, doc, how you doing?" And I was so proud of him, seeing him out there riding that bicycle already, just literally about 2 weeks after his surgery. So some people do. They take it to heart, but as it's tough, because it's ingrained. It's been ingrained in us, certainly since, Ansel Keys in 1960, the pathologist from the University of Minnesota that first advocated a low-fat diet. The fat came out of everything. That was the demon, and sugar went into everything.
Replaced with sugar. Yeah. So what does your daily diet look like nowadays?
I thought you might ask me about that, and I listened to you guys talk quite a bit and preparing your food or whatever. And so maybe just give you part of this is probably just my mentality, and part of it is just when I started, there was not, I'm not much of a cook, and my wife at the time, that she loved her pastries, so I've never counted calories. I've only counted carbs. So when I started, and I've changed through the years now. So when I started, I was making sure I was eating meat. I mean, I remember my first meal, because I thought, this is blasphemy. I got up on a Saturday morning. I'm starting on a Saturday morning, and I had sausage and bacon and eggs. And I looked at that and, okay, you know how my brain was fixated for all the years of training. This just
no
isn't
fat.
right. I can't eat this stuff. And I had that day, and I've pretty much stuck with it ever since. Not that thing. So this morning I made about a quarter pound of sausage, and I threw some cheese in with it. I made like a scramble, and I cracked a couple of eggs and threw it on at the end, and that's what I ate. And but when some of the low carb breads and keto bread came out, I would take you couldn't get anything to eat in the cafeterias. So when I would go to work, I took my lunch every day, and I would take cheese and just maybe meat, just cold cuts, cheese, meat. I really reduced my grains, and I've never been a huge fish eater. I like shrimp. I like certain fish, so I've been bad about that. But I'm just eating meat, cheese, and eggs. That's what I eat. And like when I'm playing ball, what I will typically do, a lot of the hotels where we stay, they're going to have a little buffet. Well, you can almost always get eggs. You're going to almost always have sausage or bacon. So I have that. And then I take the low carb protein shakes that you can get, that Premier Protein makes them, Atkins makes them now. And I will have one of those in the morning. And then that's all I have all day until we get finished playing. And I try to get the extra protein then, because your body can metabolize the protein a little better to make the glucose that you do need. So that's, and then I heard you talking before about protein, and it's like my wife does more, Betsy does more. She tries to get a little more protein than I do, although I get much. So I kind of got off subject. I will eat broccoli and cauliflower. I'll eat green vegetables. So that's what I have my meal. No potatoes, no rice. The biggest thing was toughest for me to give up was rice and fried rice, because I absolutely loved that. If I'd go to the Japanese steak place, oh my God. But I just didn't, once I made the switch, I didn't have any problem. I just didn't have any problem with not having that. And again, listening to Dr. Savas, he talks about carb addiction, and I know that's true because I know one of my daughters is like that. She just, and I never had any trouble with that. But Betsy and I have expanded our diet. We've got a pressure cooker. We like to just get the cheapest meat we can get and throw that in, and we'll throw Brussels sprouts in with it, and cauliflower, and some wine and a beer and seasonings, and you pressure cook that, and it just makes a great stew. We can eat on that for dinner until it's gone for 3 or 4 days.
Yeah. So
yeah, I've just pretty much stuck with meat, meat, fish. I consider fish meat, but meat, eggs, and dairy stuff, and then basically green vegetables.
Yeah.
I quit eating fruits, and I'll tell you how sick I was. Okay, I thought I've never been a big soft drink person. I drank soft drinks when I was a kid. But I kind of, my family was not, we didn't, well, my mother she was not a high school graduate, but she got her GED and she went back to college and got a master's. She ended up teaching school. But when I was younger, we didn't have a lot of money. We didn't buy soft drinks. We bought milk. So we had milk and cereal. But anyway, when I got into college and medical school, I didn't drink much in the way of soft drinks. I drank fruit juice because I thought, hey, that's good for you. Yeah, now I know it was as bad as drinking a Coke, so anyway.
Yeah. But we believe that. We've believed a lot of what we've been taught. And like you said, before we started recording, is that you weren't taught at medical school any nutritional advice.
No.
But even if you had been, you would have been told low fat, more vegetable, more vegetarian, all those sorts of things.
We got the food pyramid.
The healthy whole grains.
Which reminds me, so I've been teaching a class to the second year medical students at IU, because we have a regional campus down in Evansville. I've been doing that for 25 years or so. And for whatever reason, this year, I usually just taught colorectal, colon cancer, GI bleeding, inflammatory bowel disease, that kind of stuff, anorectal disease. but this year they assigned me their nutrition. And this, I don't know if they get any of this in any other year. It's 2 hours. They got a little 2-hour nutrition class. So they keep a dietary log for themselves for a week or something like that. And they give them some reading material. And to the credit of the medical school, they really emphasize to them, take into account the patient's socioeconomic background. Don't assume that everybody has the same means and resources to be able to buy good food. And so I like that part of it, but they're still using the dietary, what they call it, dietary guidelines of adults, or the USDA guidelines, which is 45 to 65% carbohydrate, and fruits, and the whole fruits and vegetables thing. So I told them when they asked me to teach that class, I said, I will do it. I said, but I don't know the old guidelines, and nor am I going to learn them. I did, because you can pull up the pie charts. I've got my little yellow notepad that I carry to make notes on. I've got it stuck in there somewhere, just so I could look and see what it is. And when I told the person who's in charge of the center, I said I may do something a little bit controversial when I get in there. She was all for it. And that's what I talked to them about. I talked to them about some of the things we're talking about right now, about the importance of lowering the carbohydrates in the entire population's diet, and how we can prevent disease by doing that. And I told them, go and look at the data. Just look at the data. I talk with them about the effects on cancer and cancer treatment, and diabetes, and the fact that you don't have to cure diabetes if you prevent it. And again, I've heard multiple. Dr. Graham, that was on.
Graham Phillips.
Graham Phillips. Yes, that was great. I loved what he had to say about that. Yeah, we have, and we've all been guilty of that. It's like we would treat a disease when they had it rather than push prevention. And there's a lot of stuff out there.
But there's no money in prevention, Jim. There's no money.
Yeah, I get it. Yeah.
So, I think the pharmaceuticals companies want to make us well enough that we can carry on living, but not too well, because we still need these drugs so that they can make their profits. So keep us alive to keep consuming the medication, but not too well that we don't need it at all.
Yeah. It's interesting that I was listening to someone's lecture, and I don't remember who it was. It may have been Dr. Steve Finney. And he was talking about the fact that before insulin, okay, we already knew that you could I don't want to say you cure diabetes, but you prevent the complications of diabetes by putting people on low carb diet. And then as soon as insulin came out, there was the big impetus. And I sort of get it. Well, Dr. Ian Lake, I think, talked about this. Yeah. That, okay, well, now you can go ahead and he's type 1 diabetic. If
type
I'm not
1,
mistaken. That, okay, well, now you can just go ahead and eat like everybody else. Of course, everybody else is back in the 1930s. I don't think people ate like we do now. They didn't eat as much sugar, I would venture to guess. But well, yeah, you can then you eat like everybody else. But what we now know is, and I've been saying this for some time, and I'm sure other clinicians, because I don't treat diabetes, we're not treating their diabetes with insulin. We're treating their blood sugar, right? I mean, you've heard, I think Dr. Lake may have even talked about that. So we keep their blood sugar low enough that they don't die of a hyperosmolar diabetic coma. Okay, that's what we do. But the high glucose level and even worse, we're making their insulin levels even higher, because they're not a type 1. They already have high insulin levels, and we know that that's an inflammatory, and it's a growth factor, and that's probably what contributes. That's one of the things contributes to cancer.
Yeah, absolutely.
Yeah, so it's
so you got the environment of the sugar and the insulin that's creating the growth. Why wouldn't cancers proliferate?
And they do.
Yeah. And there's lots of cancers that feed on sugar. I'm not saying all of them, but there are lots that feed on sugar.
We know that there are 8, and I never can remember them, but the ones
breast,
colorectal, I believe pancreatic does. I know for sure. I think that prostate does. and I think maybe lung. I'm not positive about that. I mean, yeah, I would have to look it up. But you know, the certainly three of the four big ones, because lung and breast are the top two in women, and lung and prostate are the top two in men. Colon cancer is third in both sexes. So, you know, colon cancer is the third leading cause of cancer, and it's the third leading cause of cancer deaths in the country.
Yeah. So I just wanted to touch on IBD. Is IBS, irritable bowel syndrome, linked to, I mean, is there a link? And if you have IBS, what were some of the things that you would recommend?
Well, I don't know that there's a link between irritable bowel syndrome and inflammatory bowel disease. Now, that said, I don't know what we're going to find in the future. And I'm not, it's been a couple of years that I used to go to the Cleveland Clinic colorectal conference every year, and they always touched on both of these. So we may at some point find that although we don't find any inflammation or, you know, any demonstrable pathology in irritable bowel, that maybe those symptoms are being caused by, you know, something subclinical or something that we just don't know about yet. But generally speaking, you know, and I've got irritable bowel tends to run in families. Well, everything runs in families, and I have, you know, one of my daughters has irritable bowel, and her mother had irritable bowel. And so when we evaluate people, when people come in with irritable bowel, of course, we're concerned about, okay, do they have inflammatory bowel disease, or, you know, could they have cancer? Not so much in the younger patients, but certainly older patients. So we do an evaluation to look for inflammation and look for a cancer. And if we don't find one, then we tend to treat them. We'll put them on fiber supplements, because fiber tends to, because what's going on in irritable bowel is that they've got just overspasticity of their colon, and sometimes even the small bowel, and so that can cause them. Most patients will get cramping and bloating, and they'll get loose stool, and people will feel bloated sometimes even if they're not, because your gut only senses pain when it's inflamed or when it's under tension. So if it's cramping, if it's squeezing real hard and it's under tension, that'll cause you to have cramp, make you feel bloated, even though if you measure your girth, it may be the same. So those are the symptoms people get. So we typically will treat people with fiber, because fiber decreases the pressure with which the colon, it stimulates the colon to squeeze normally, to do its normal peristalsis, and it decreases the pressure at which it's got to push stuff through. Unfortunately, it doesn't work for everybody. Irritable bowel is very frustrating. We will use antispasmodics like Levsin and Bentyl, and they're just antispasmodics. They slow the muscle contraction in the bowel, and sometimes those work. There's been,
go ahead. I'm just going to stop you there, because when you say that you suggest for people to have fiber, is that a dietary fiber or is it a medication?
No, I'd say it's just dietary fiber. And
in what form? Because if somebody says, I don't know what you have in America, but here in the UK, it's probably the same because it's Kellogg's, maybe not, bran flakes.
Yeah, now, well, we tend to use in the States, we use psyllium husk.
Okay.
Most of which I think comes from India. And so we have Metamucil, and well, every drugstore chain has their own. So it's over the counter, and it's the only fiber. It's a soluble fiber, and it's the only fiber that increases the water content of the stool, because that's how fiber works. You know, it holds water in the stool. And it also, if you watch some of the experts on lipid metabolism and trying to reduce your lipid numbers, if indeed they're even important, but they have found that like psyllium will lower ApoB, which is one of the lipoproteins that carries fat, which is probably a bad one. That's one that probably is related to atherosclerosis. So that psyllium fiber will help reduce that. So having that in the diet will help. You know, so do omega-3 fatty acids, and so does olive oil. So psyllium is the only fiber of all the vegetable fibers that will reduce, increases the water content of the stool. And then in doing that, it lowers pressures that are required to push it through. So that's what I use most.
So
I stayed away from the grain fibers.
Yeah.
Yeah. Like that.
So how much would you recommend? Because the other thing is some people say they change their way of eating. So they've moved to low carb or keto, whichever, is their preference.
Yeah.
And then they say they're having trouble with bowel movements.
Yeah.
Now, I'm sure that is just a change in the way that they're eating, but
right.
Would you recommend, or would you suggest that using psyllium at that point as well?
Yes. In fact, I was using psyllium before because of my cholesterol. So I was already taking some a day because, you get the sugar free, there's no calories in it. And it binds cholesterol. And that's how it works. So you don't get return of some of the cholesterol via the gut liver, metabolism. It helps. So it helps you get, and so you'll lower your cholesterol your total cholesterol about 10% if you're taking psyllium daily. So
is that a teaspoon or in a glass of water?
I would tell people to take like a couple of teaspoons or a tablespoon a day, and here's what I told. Now, so I was taking it not for constipation, although I was already on it before I started low carb. So I don't know if I would have noticed the change or not, but I would always have my patients, and we always had them take it after surgery. Like we did a bowel anastomosis, we want to bulk their stool up because part of what allows, stretches the bowel and allows it to return to its normal function is having normal stool pass through. But for anorectal surgery, especially, you don't want them constipated if you've just done some kind of surgery down there, because that's terrible pain. It's like your feet, your hands, your anal canal, and your head and neck area are about the most sensitive areas in your body. So yeah, we would have people use it for that. But I encourage most of my patients, I was encouraging to use psyllium, and because I figure it's not going to hurt them, it may help them. But for irritable bowel, you get some people where you just almost can't do anything for them, which makes me think that there's some underlying cause that we don't know about. Well, we don't know exactly what causes it. We think it has to do with autonomic nervous system, because we definitely know. And I used to always tell patients, all of us, our gut kind of controls us in more ways than one. And think about it. If you get a little bit excited or tense or nervous, it will affect your gut a little bit. I mean, it does that even for me, and it does it for everybody. If you travel, most people, you get constipated. The most common scenario I would see for patients who came in with an anal fissure, which is like a little crack or tear in the lining of their anal canal, they traveled, or they've done something different. They maybe been in a hospital for something, and then they got constipated and they strained and they had a real hard stool and it caused them a crack or tear. So lots of things affect your bowel pattern. And we do know one of the ways to differentiate between, let's say, a cancer that maybe has caused a change in bowel pattern or inflammatory bowel disease, other than maybe having, with inflammatory bowel disease, quite often you're going to get bleeding. It's going to be more chronic. And same maybe for colon cancers, is that with irritable bowel, if most people will not wake up when they're sleeping. When they go to sleep, they don't get up. In fact, one of the things that people came in with changing their bowel pattern, I always ask, are you getting up at night? If they got up at night, that's an alarm bell for me. Okay, that's, I got to be more concerned that they have inflammatory bowel disease or that they have colon cancer or something else going on. So irritable bowel, bulking agents, antispasmodic agents. Some docs have used the SSRI, the selective serotonin reuptake inhibitors, the antidepressant agents, not because the patient's depressed, but they seem to affect the autonomic nervous system a little bit and help with irritable bowel. I never use those that much. I believe it or not, a lot of times, if you work a patient up, you do a colonoscopy and everything looks normal. And even if it looks normal, we biopsy them because something, and this goes again to something that we've only learned in the last few years, there's something called microscopic colitis, and they've got two different forms. And so the bowel looks normal. There's no ulceration, no bleeding. Mucosa looks nice and pink, nice blood vessel pattern, but you do a biopsy and you find inflammatory cells under the lining. So not causing, so we always check for that anymore. So that's something that where people used to get diagnosed as having irritable bowel, but we know it's microscopic colitis. and it responds to some of the same things that inflammatory bowel disease, because it is a type of inflammation. It's just not involving the mucosa or the full thickness of the bowel wall, but it is causing them symptoms. So yeah, it wouldn't surprise me if we find other better explanations for irritable bowel. But right now it's kind of, I like the term we use in medicine, it's idiopathic. It means we're idiots and we don't really know.
We don't know. Yeah. The doctor doesn't know.
Yeah.
So they'll just tell you it's idiopathic. Yeah.
Yeah.
So with inflammatory bowel disease, would people respond well by removing the grains and the seed oils that cause inflammation?
I think yes. And the last couple of conferences that I went to where they discussed inflammatory bowel, and we're talking about a good conference, international conference the Cleveland Clinic has each year. Now, again, it's been about 2 years since I went, but we're seeing stuff in the colorectal surgery literature now as well. First of all, they were focusing on the microbiome. Okay, my head's getting hot. I better take the hat off. Anyway, so there was a big focus on the microbiome. And I had a theory, and this may still apply, in addition to the whole grain theory as well. It's probably a complex issue. Crohn's disease was first described by one of the doctors' name was Crohn, and so it got his name. There was also another investigator, but it's a longer name. They just dropped it. So it's Crohn's, they call it Crohn's disease. But the first case was described in like 1932, and when I was in medical school in the late 1970s, you know, it was more common in Ashkenazi Jews and European populations. I mean, obviously we had it in the United States, but blacks didn't have it. They had, well, black people don't get it. So anyway, now we've seen a pandemic of inflammatory bowel disease, and we see it in all races, colors, and creeds. And
Jim,
did I lose you for a second?
Yeah, I got we got the it was quite a long time actually.
Oh, okay.
So I got the bit where Crohn's, it got his name from Mr. Crohn.
Okay, yeah, yeah.
So we need to go right back to there. Really.
Okay, so Crohn's it was first described by one of the physicians' name was Crohn in about 1932. Before that hadn't been described. I'm not so sure about ulcerative colitis, but now we have a pandemic of inflammatory bowel disease. In my mind, and this is just me thinking, I've not seen any studies to definitely show this, but I thought, okay, well, what happened around that time? Well, in 1929, penicillin was discovered. And so what has happened since then? We've had an explosion of antibiotics and antibiotic therapy for people. And so I always thought that's got to have something to do with it. That changes our microbiome, you know, even if you only have one dose, and most people have multiple doses through their life. Now, knock on wood for me, I've only had antibiotics, I mean, handful of times. But some people are on them on a regular basis. So in my mind, I'm almost certain that has to be related to it. And especially then when I saw the research coming out that they're now relating inflammatory bowel disease to some type of changes in the microbiome. And there have been trials using probiotics to treat it. Now, we haven't found so far that using probiotics for inflammatory bowel disease seems to help. We're still stuck with using anti-inflammatory medications like the mesalamine preparations, steroid preparations, and then the anti-tumor necrosis factor things like Remicade and, Inflamab, those things. But we're using those to treat the inflammation once they have it. So I think there's probably a role of us changing the microbiome with our use of antibiotics. And one of the big things that we took care of as colorectal surgeons, and first question I asked people when they came in with diarrhea, have you been on an antibiotic recently? So we're not so concerned with infectious diseases anymore. And most of those, if you support the patient, they'll get over them anyway, whether you culture them and treat them or not. In fact, there's a little bit of a push now not to treat some of that stuff if the patient's in trouble, because you don't want to affect their microbiome. But that was one of the first questions we asked, because Clostridium difficile has become, endemic. Any of us have been in a healthcare facility, probably carry it in our gut. And if you come off the good stuff in your gut, then it can overgrow and make you sick. So we already have that issue. So, there's almost, I think there's almost no question that changing our microbiome with antibiotics makes a difference. But again, getting back to using probiotics, they do seem to work to help in the treatment of C. diff colitis. Okay, they seem to help with that. And in fact, we do fecal transplants now, which sounds very gross, but this hospitals now have all cultured normal stool, and there's no poop in it anymore. It's just they've got the bacteria growing in a broth. And so if we have somebody that has C. diff colitis that doesn't respond to Flagyl or one of the other antibiotics we use, vancomycin, then we'll do that. And you can do it. I had a nurse down here several years ago who's also a young lady who's also a cancer survivor, colon cancer patient. I had her just get some of her husband's stool and put it in a blender, because in fact, she was a GI nurse, and blend it and give herself an enema with it, and it got better. So we know that'll work. We know just putting normal bacteria back in the gut will help. And so I
hope she didn't use that blender afterwards.
Yeah. Myself as well. Yeah. Anyway, but now the latest thing that I'm reading a little bit about, and I'm not an expert on this at all, is they are looking at the proteins in grains, and the high grain consumption has been going on for not that many years. We didn't start having agricultural, what would you call that? What's the right time? Not agricultural. Almost mechanized farming.
The combine harvesters.
Yeah. That's a relatively new phenomenon in human existence. And so they're looking a lot at the various proteins that are present in grains, and wondering if that's not some of the cause of inflammatory bowel disease as well. And then, as we know, the grains are just, probably should only be eating them seasonally anyway, and they contain a lot of carbohydrate.
Yeah. And Dr. William Davis, in his book, Grain.
Oh, he's got the one, Wheat Belly.
Wheat belly. That's the one. I'm saying grain belly. It's not wheat belly. He was saying how they've modified the wheat since the combine harvesters have come in to make it shorter and straighter, so the combine harvesters can harvest the wheat.
Right.
And that change, the way they've changed it is what really irritates our guts at the moment.
Yeah. And that, I don't know enough about it. I've heard him speak as well. In fact, I think I've got his book. I haven't read it yet. I got Dr. Fenney's book. And anyway, yeah.
So before we finish, is there anything else that you would have liked to tell our listeners that you haven't already mentioned?
If there is, I can't think of it. I put it that way. Yeah. We've talked about a lot. I told you it's hard to shut me up when you get
going. No, it's good. I have less work to do when you keep talking. So how can people get in contact with you if they want to?
Well, you could go, we have a website. It's easy. It's colondocs.net, all lowercase letters, colondocs.net. We have a YouTube channel, and I don't know how I got this name, but I did. It's Tri-State Colorectal Surgery. So that's it. We've got a YouTube channel, and I put a lot of informational videos on there, and I also put a lot of written information about various colorectal issues on the website as well. And then we have a Facebook page, and it's just Tri-State Colorectal Surgeons is the Facebook page, so they can get a hold of us that way. There are phone numbers there. If I don't know that I want to put my phone number out on the web, but if someone called the office, they would certainly get my number to them, or they would get their number to me so that I could call them. And I actually do that quite a bit. I mean, I'm notorious in my hometown because, I've lived there most of my life. I went to grade school and high school, and I actually went to college there. University of Southern Indiana is in Evansville. And then I was gone for like 10 years or so, going to medical school and doing my surgery training. But then I came back to Evansville, which was, for me, was the best thing I could have ever done, because I wouldn't know my wife. I wouldn't have my wife now had that not happened. But for many other reasons. But one of them is, and my staff teases me because my other three partners are not from Evansville, and our practice administrator, that I know everybody in town, and I really don't, but enough people know me, they know how to get a hold of me. And so they'll either call the office or they'll call somebody they know that knows me and get my number. And I enjoy talking to people. So yeah, if I can't answer your question, I'll tell you I can't. You know, sometimes I say, well, if I don't know the answer, I'll make something up, but I really won't do that.
Yeah. And I was just thinking, because if it's okay to share this, and you can say if it's not, but your wife, Betsy, got in contact with me, and then she told me about you and said, and I said, oh yes, you'd be a really good guest to come on. But she told me your story of how you met. Do you want to share that with our listeners? Because I think it's quite sweet.
Well, I will, because I have a little bit of an aversion to Facebook, although I use it all the time now for a practice. And I used to use it, just to tell you a little bit about that. I used to use it, my own private page, because the softball team I play on, or one of them, because I play on a 65 and over team now, but I still play on this other team. We were sponsored by Pabst Brewing. That's a beer. That's a beer brewer in the States, and they make something called Old Style. And Old Style was a beer, and people who know of the Chicago Cubs, Old Style was like the sponsor or whatever for the Chicago Cubs for years. Well, most of the guys on this softball team are from Chicago, and that's not even how we got the sponsorship. But Old Style wanted, when we played ball, and especially when we won, they wanted stuff on my web page, or not my web page, on my Facebook page, and then they would take that and they would put it on their Facebook page. So I have a private Facebook page, but then the one I'm on most of the time is the Tri-State Colorectal. So in March of 2020, during the pandemic, I was down here in Florida with just spending time with my daughter then, because I was having a house built. And you know what? It's nice to be in Florida in March. I could ride my bike every day. Well, one day on Facebook, anybody who's familiar with this, you see those little things that says people you may know, suggesting friends. And I saw this lady on there, and she went by her maiden name, Betsy Gorman. And she was standing doing what I thought was a yoga pose. And as it turns out, it was. And she was standing on kind of, it looked like a bluff over a lake. And she was in Sweden. She has some good friends who live in Sweden. So I sent her a message. I use what do they call it? Messenger or private whatever it's called.
Yeah, Messenger.
Facebook. I don't use that very often either. I said, is this Betsy Gorman, graduate of Wrights Memorial High School, class of 71? So that was maybe the first week of March. And we were just going into shutdown over here, right? So I don't hear anything until my home was done. My daughter went up with me to kind of help me get stuff moved in. And I hear my phone ding, and I have just a plain old ping for that messenger alert. And I thought, well, I wonder what that is. And I go pick it up, and there's a I'll just call it a text. It is text. Yes, Jim, it is. And I thought, okay, that was very brief. So I sent her a message. Well, I'm nice to hear from you. I hope you're doing well. Just something to that effect. I didn't hear anything again until June. And then I get a message from her, and it's, sorry, I just don't do this social media stuff very well or very often. So I sent her a message back and saying something to the effect, well, I don't blame you. I probably would not be on Facebook at all, except for softball team I played with, and colon cancer survivors that have a network. That's in fact why I first got on Facebook. They had a network, and I worked with this. It's a national group. It's called the Colon Club, and it's people under the age of 40 who have had colon cancer. I said, so I wouldn't be on Facebook except for that. So then we played in a tournament in probably then in mid-July, and my phone was in the vehicle, and we played like 9 games in 30 hours, and I mean, absolutely beat. We're getting in the car. We had to drive 6 hours to get back to Evansville. We played down in Chattanooga, Tennessee. And I picked my phone up, and she's got a message on there. She said, okay, here's my story. I had stage 4 endometrial cancer in 2008, and I had surgery and I had chemo, and I guess I'm a miracle because I'm still alive. And so then I responded back to her, yes, you are a miracle if you had stage 4, and then here it is, and I think to this day, and I think she went more low carb when she met me, but she always did low carb and she always worked out. And so she never, now she, like a lot of us, was trying to restrict her fat because that's what she'd been told, but she also, and Betsy weighs all of like 90 pounds. And by the way, she's an Army vet. I hear Louise talking about her husband. So yeah, she went in the Army for 3 years. Her dad, who she was very close to, had a horseback riding accident and was in a coma for 3 years and passed away. And she dropped out of school after her 3rd year at IU and went in the service. And then after she finished her stint in the service, she went back to school and got her master's, and I ended up at that. But so that conversation then led to us deciding to get together for coffee. And it's funny how we got decided to get together we didn't talk to each other live. We were just texting. And I sent her a message one night. It's Friday evening, I remember. I said, we really should just talk on the phone sometime. And she said, okay, maybe tomorrow. And we both go to bed at 9 o'clock at night and get up at 6 in the morning or 5. I get usually 5 in the morning. So I'm up getting a cup of coffee. And so Dr. Savis, when he talked about his coffee, I made me think of my situation. I'm getting a cup of coffee and my phone rings. And not only does my phone, I was in a call from her, it's a FaceTime call. I never used FaceTime before. And she says, I hope you're decent. And she's out walking her dog. She's out hiking with her dog. And that's the first time we saw each other really since high school. And from there, here we are married 2.5 years later.
So you went to high school together, you separated for what, 50 years? No, maybe.
Yeah, it would have been, because we just had our 50th reunion last year. So 48 years, let's say. Yeah. Didn't see her for 48 years.
You got divorced and her husband died, and then now you're together.
Yeah.
It's so sweet. It's really sweet.
And here my brother Jose, whom I told you about, who he's originally from Spain via Cuba, came to live with us in 60 or 61. Exact same story, same high school, because it's one of the Catholic high schools in Evansville. So Jose and his wife went to high school together. She became a nun. He got married, and then some years later got divorced. She actually married. She dropped out of the order and married and had 2 sons. Her husband passed away. They then got back together and got married. So I have, my really only living immediate relative, other than my children and cousins and stuff, is Jose, and of course we are brothers, because we grew up together. We still see each other every other weekend or so. And so he and Billy, and I mean, you couldn't write that. They wouldn't accept that as a movie script, I don't think.
No, it's too nice. It's too nice.
Yeah. So it's
so yeah. Before we finish, hit us with your 3 top tips.
3 top tips. So I kind of wrote these down because I've heard you ask people these before, and I may change them as I look at them. Well, the first one is, I'd say, going back to my own experience, you can't exercise yourself to good health. Exercise is important, but diet is just important. And we all know of good athletes, well-trained athletes, who died of cardiovascular disease because they had no idea what was going on inside their body. They were suffering from insulin resistance. Their blood sugars may not have been high, but the insulin itself, it causes inflammation in your vascular tree. I mean, anyone who's listening to this, they've heard the other people are a lot more expert on this than I am talk about that. So that's one thing. The other thing I would say, and this went to myself, be your own healthcare advocate. I think a lot of people, and being a physician, I know a lot of people are afraid to ask questions, or they're afraid to go against their doc, and don't. You be your own healthcare advocate. And if your physician if they don't want to talk to you, then find somebody else. Yourself, and now a lot of this stuff you can find out on your own. You don't have to go to medical school. You can watch lectures. I'm talking about real medical lectures. You can look at the research yourself. You can watch experts talk about it. And if you have a healthcare provider who won't listen to you, or just wants to, put you on a statin, or tell you to be on a low fat diet or whatever, wants to increase your insulin level, find somebody else, be your own healthcare advocate.
Yeah. And I think even in the UK, where we have the NHS and you're fairly limited to who you can see, so you can't choose your doctor, I think you can still, if you feel you're not getting the right advice or you're not being listened to, I think you could still look for another doctor, even within a practice. Maybe you see a different doctor within the practice,
right, yeah.
Or maybe you just go somewhere else, maybe privately. It's
right.
It's expensive, but maybe it's worth that 50 or £100 to get a different opinion, especially if you don't feel like you're being listened to.
I myself started treating myself, because my primary care doc, he didn't like to hear my discussion about statins and fat, and he knows I've been through 2 primary care docs because they're older than me and they both retired. I'm on my 3rd one now. And when I first went to see him, I told him on a low carb diet. And I said, I asked him if he used that with his patients. And no, he doesn't. He said, well, I can't do that. He said, we live in Southern Indiana. Now, this won't mean much to people around the world, but if you're from the States, it might. We have a high rate of obesity in Indiana. And it's the kind of the very large German and Irish population here. We don't really have like ethnic groups. The people been here so long, they don't, other than your name, they don't know what your ethnic, what your background was. But a lot of farmers, okay. And he says to me, he said, well, I can't put people on a low carb diet because you know what they would do, Jim? And I said, well, he said, they'd eat bacon. I said, what's wrong with bacon? So I've had that conversation with my own healthcare provider, and I stopped the statin that he had me on. And I do take a statin. I take a very low dose, and I base this on recommendations I got from physicians on the internet. Okay, because of my own personal family background, I'm a person who should be on one very low dose because they do have not for the lipid effect, for the anti-inflammatory effect. So I've had to do that, and I know it's hard for me, and I'm a doc. So yes, you just take. You're your own best advocate. Take care of yourself.
Yeah.
And the third thing I would say, I'm going to use a term that a great friend of mine that I play softball with shares my mother's maiden name. So he and I always call each other cousin, although he's from Chicago and who knows. But I like racing. I like IndyCar, Formula One. I spend my Sunday mornings watching Formula One. I love an expression they use: push, push. I don't know if you ever watch racing. There are going to be people listening to this. They do push, push. So one day out of my mouth, when we were in the middle of a game, I'm kind of a chatterbox there too. I come into the dugout and I'm saying something. I look at Gary and I said, hey, Gary, time to push, push. Okay, because push, push is we got to go harder now. And he started saying it all the time. And I thought about that when I was thinking about this. And here's what my push, push applies to. Push, push always on your friends, your family, and especially the medical community. Push them to do the right thing. Push, push.
Yeah. That can sometimes backfire though, can't it?
I know. What you got to do is you just got to tell them, like with my office staff, I tell them and I just, then I let it go. You don't want to be overbearing. That's a tough judgment call. When you're being overbearing and you're doing it for their own good. And something that I've used with people through the years, I've used with my own kids. If I didn't love you, I wouldn't tell you that. And I said that to one of my partners one time. I said, if I didn't love you, I wouldn't say this to you. If I didn't care, and I do care.
That is really powerful, actually.
Yeah. So that's I probably heard that from some, most of the crazy stuff I come up with, I heard from somebody else. So, so I told you I might learn more from the two of you than I know on my own. Yeah.
Yeah. Jim, thank you so much. It's been really fascinating talking to you. I'm really glad that Betsy reached out to me and introduced us.
Well, thank you for having me. Yeah, and you're welcome. I really looked forward to it. I did, and it's because I've had a chance now to listen to your podcasts, and And, you know, I drove down here. It's about a 15-hour drive. I'd make it all in one day. So that's what I do when I'm driving. I pop on all these different, what I call educational podcasts. Yeah, they are educational.
Yeah, me too. I'm always listening when I'm driving.
So
thank you so much. Thank you for your time.
You're welcome. Hope to see you and talk with you again sometime.
Thank you.
Okay. Bye-bye.
Right. Let's just stop that. Stop that. Fantastic. Okay. That was really good.
Hopefully we weren't on too long.
We did, but
you can cut. You can edit it, right? Yeah.
I tend to leave it, most of it. I'll cut the little bits where we had a few blips, but
I think it was here that we had issue, because all of a sudden you froze, and then when you came back, I got a little thing that said internet connection is weak, but it's been fine the whole time, because I said this is a medical office here.
Yeah. It was just that one. It was about 2 minutes. I lost you.
Yeah. Okay. God, we covered a lot of stuff.
We did. I think it's going to be a really great episode.
Well, thank you. I hope so. Yeah.
I think so. We'll see what I say. I'll see. Well, I know, because I get some comments sometimes. So let me give you an idea. It's not exact timing,
right?
Because I have got my mouse has gone. Got a bit of a backlog. So I've tentatively got you in for the middle of June.
Okay.
But I've also, do you know Pam and Doug from the Low Carb USA?
Yes.
So I've reached out to Pam and see if she wants to come on with enough time to promote their low carb San Diego. So I might have to shift things around. But I'll let you know the week before. I'll email you.
I mean, it does. You do it whenever you want. It doesn't matter to me. You do what works best for you. Yeah.
Fabulous. So. You sent me your bio, didn't you, with your photo?
Yeah.
Fantastic.
I had trouble for whatever reason. I had trouble with Mac. I use a Mac Air. I think sometimes it's the Mac.
Yeah, possibly.
I think I ended up copying it, printing it. I don't even remember now how I did it.
It's fine. If I need anything, I'll let you know. And I'm actually in the process of moving my form away from that Google